I'm very, very pleased to welcome you to this session today. My name is Gillian Kolla, and I'm so pleased to be introducing Dr. Nanky today. Both Nanky and I are coming to you from Toronto on lands that should remain under the full jurisdiction of the Wendat, the Anishinaabe, the Haudenosaunee, and the Mississaugas of the Credit Nations. Nanky is going to be our presenter this morning and is a primary care physician at the Parkdale Queen West Community Health Centre. I've learned so much from her, particularly due to the ways in which she focuses on examining historical analyses of structural violence within the healthcare system and on learning from grassroots response to achieving health equity. And I'm very grateful that she's here today to share some of these learnings with us. I'm excited for this presentation, and Nanky, I'm going to turn it over to you. Just one quick technical note first, please. Feel free to put questions in the chat as we go along or comments, and we will also do the Q&A at the end of the session in the chat as well, and I will be popping back in to help with that at the very end. So Nanky, it's over to you now.
Perfect. Thanks so much, Gillian. Always nice to hear your peers and friends talk about you in more formal ways than I'm used to. So thank you to everyone who's able to join us this afternoon. I know there's a lot of concurrent, incredible sessions happening today, and I'm excited to attend a number of them later today as well. My hope in our next, 50 to 60 minutes together is really just to hope that everyone leaves the session today with a better understanding of the root causes behind overdose deaths, more typically known as the opioid crisis. I hope by the end of the session, you're able to understand why I would call it the drug poisoning crisis. And also leave, for those of you who are healthcare practitioners, healthcare workers with us here today, leave with a sense of understanding of all of our collective responsibility as healthcare practitioners to move from reinforcing rather than reinforcing to move towards actually dismantling a lot of the oppression that people who use drugs face, both within the broader society, but also within our healthcare system. So I know Gillian initiated with a land acknowledgement today. I also wanted to start with a land acknowledgement myself. And I think, it's safe to say, I don't think we can talk about the drug poisoning crisis. I don't think we can talk about drug prohibition and the harms of the war on drugs, or, more aptly known as the war on people who use drugs, without really talking about the long-seated racist, gendered reality of settler colonial violence in so-called Canada. We know from data from the First Nations Health Authority in BC that Indigenous people are 5 times more likely to experience an overdose and 3 times more likely to die of one in comparison to non-Indigenous residents in so-called BC. And particularly Indigenous women are 8 times more likely to experience a non-fatal overdose and 5 times more likely to experience a fatal overdose than non-Indigenous women in BC. We know that in Saskatchewan, for example, despite the fact that Indigenous people make up 16.3% of the population, they represent more than half of opioid-related overdose deaths in the last 3 years alone. So all to say, I really, can't talk about structural violence and overdose deaths, which is the title of today's conversation, without really naming this particular reality of ongoing settler colonial violence. And so I wanted to do my land acknowledgement both in recognition of the ongoing violence, but also to recognize ongoing Indigenous presence despite 500 plus years of attempted genocide. And with that, I'd like to, affirm that I firmly believe the territories that I'm speaking to you from, Toronto, should remain under full jurisdiction of the Wendat, the Haudenosaunee, the Anishinaabe, and the Mississaugas of New Credit First Nations. Okay. And for those who are interested in learning more about the connection, I do encourage you to read the CTV News article here to learn about the current statistics and the rate of violence that we're talking about here. And then also encourage you to read this article that was published in CAMH in 2018, so the Canadian Medical Association Journal, titled Reconciliation in Canada's Overdose Crisis, Responding to the Needs of Indigenous Peoples. Okay. So I don't have anything to disclose in terms of commercial support, and I do not have any relationships with commercial interests to disclose. So I'm hoping we could use the chat for this instead of doing this as a poll question for the sake of time. I'm hoping you could, feel free to submit your answers in the chat. You can send it to everyone, or you could send it directly to me if you want to stay a little bit more anonymous. But what's your response? What's your initial reaction to this question? That our healthcare system does not replicate or amplify power and privilege as it exists within society. Do you agree with that? Do you disagree with that? Strongly, so lots of D's with some exclamation marks. I appreciate that. And it's okay if you are unsure, but it doesn't sound like it. Okay, perfect, great. It's always a little bit of a pulse check for me to kind of get a gauge of where the audience is at. So thank you for entertaining me with that question. And then what about this question? I have a good understanding of how structural violence and oppression exists within our current healthcare system. Perfect, okay. And when I ask that question, that can be, that's not a question around your intellectual understanding. That includes your lived expertise and understanding of that as well. So I appreciate everyone submitting their responses. And then this one is a little bit more of a personal question. I'm asking all of us, including myself, to really, ask myself, how good am I as an individual in picking up when I may have behaved in a particular way, whether through verbal or nonverbal communication or through my actions, that may have actually made someone else feel marginalized, excluded, or dehumanized as a result of our interaction. Do you feel like that's something that you're good at? You can pick it up right away, or it takes you a couple of days and you're like, I know that interaction didn't go well. I think I actually made that person feel X, Y, and Z ways. And some people are not sure. That's totally fair. I think sometimes people can pick that up based on the communication you receive from people that you're interacting with. And sometimes, whether you realize it or not, people may actually be communicating to you, but you may not be able to receive it. And that's part of the skills here. Okay. Thank you so much for responding. Perfect. So I'm going to move us forward here. Okay. So I'm sure if you've heard me speak before, I apologize. This is the analogy that I use. There's lots of different analogies to talk about the same concept here. People use rivers or coins or all sorts of things. I find the tree analogy the best for me. So I'll describe what I mean by that. So this tree here, the branches of this tree are termed what we would typically call the social determinants of health. This is how a lot of us learn about this within our public health education, within our medical school educations, nursing schools, all kinds of clinical education across the country and across North America. And then we have these downstream health consequences, the fruits of this tree with varying degrees of disproportionate impacts, health impacts that people experience as a result of these trees. Now, oftentimes I find when we learn about these concepts of the social determinants of health, the conversation around power and the conversation around history are usually fairly missing. So what do I mean by that? I mean, we might talk about religion, for example, without really talking about, Euro-Christian supremacy that has been part of our grounding of our country's, history. We may talk about access to healthcare or work environment or income or housing without really talking about, or people being unhoused or housing insecure, without really talking about the fact that there's a whole number of people who actually live in physical spaces and housing that far exceeds their material needs and so forth. We might talk about race, but we're not necessarily talking about racism. And I find what ends up happening, and when I did look at literature in a lot of depth, and I'll share a link to that research for those who are interested in reading more about it, since we don't have time to go into all of that in detail today. But when we go past the branches of this tree, it becomes really obvious that there are actually a lot of underlying roots, as well as a soil within which these roots are, brewed and nurtured and continue to grow, that are really underpinning a lot of these downstream health consequences. But the issue ends up being that we focus on the downstream as opposed to the soil, which I would label as white supremacy, capitalism, slavery, and settler colonialism, particularly in the context of North America, without really understanding that, these are the fact that we're continuing to ignore the roots in our education system, in our way of practicing in healthcare. Essentially what ends up happening is we learn about so-called dispossessed communities, or we learn about communities that might be at higher risk of X, Y, and Z issues, as opposed to something that we need to then therefore help or fix or, try to reduce their suffering, which is so much of what medical education particularly focuses on, this idea of altruistic care, which is very much a savior model, a model that's rooted in supremacy. And when we do that, we continue to just reproduce those downstream health consequences. So here's why I have the arrow and that message. So when we continue to ignore the roots of the issue, we continue to reproduce. So hopefully we'll come back to this. soon. And to make sure we're also on the same page here, I want to ask, how do you define oppression? Because this will be a word that, is used a lot. And I want to make sure that we're all somewhat on the same page. So what words come to mind or phrases come to mind when you think of the word oppression? Feel free again to enter that into the chat for everyone, or you can send it directly to me. And I'm happy to say it out loud without your name. Holding or keeping some people back. I appreciate that. Yeah. And I think, with that comment, what we're really getting at is the fact that it's an active process, right? Again, it's not just this thing that somehow people are just unhoused or somehow people are just disproportionately criminalized. There is ongoing actions that are leading to those consequences. Okay, perfect. So lots of other stuff: upholding supremacy, using power to limit people's opportunities. Yeah, so I think you're talking about, getting at the point of disadvantage versus others who have excessive advantage, whether we recognize it or not. Yeah, keeping others on the margins, particularly margins of power. Great, okay, perfect. And then unjust or discriminatory treatment. Exactly. Okay, so I think we're all fairly on the same page here. For me, I think about this as the fact that, certain groups of people, based on various lines of the roots that we were talking about, whether that is as a result of ableism, racism, xenophobia, settler colonialism, sexism, or heteropatriarchy, certain groups of people are able to dominate, disempower, marginalize, silence, or subordinate on others for their own benefit. Whether they are conscious of that or not, it is often as a result of benefiting ourselves or benefiting particular communities. And it is an unjust exercise of power and authority. It can use all kinds of means to actually enact that harm. And the dominating group usually uses explicit ideologies to justify oppression. And by that, I mean things like, and hopefully this rings for you in terms of how we are taught to practice clinically, we may know better. We have higher education, and therefore we have learned X, Y, and Z, and therefore we are better at determining what the right action might be. Or we may, as a result of the fact that we may know better, we are therefore more superior. So those ideologies are often underpinning oppressive behavior. And it does occur everywhere from individuals to systems. It occurs interpersonally amongst ourselves, and it occurs internally in terms of the way that we have lots of people have internalized all forms of oppression. And it also occurs within our institutions, and it occurs at an ideological level, at a societal level, much larger scale as well. Okay. I'm glad we are all on the same page with that. So I wanted to move into a conversation around back to those roots of that tree. And particularly what I was interested in is, we often talk about the roots of this tree as if they exist outside of the healthcare system. And the healthcare system is somehow immune to all of the ways that our society is structured and has been created from, the founding of the nation state of Canada. And I particularly wanted to do the work of holding the mirror onto ourselves as those of us within the healthcare system to think about how those roots actually very much not just manifested and embedded within our healthcare system, but how our healthcare institutions and system across North America has actually been a leading force of building, creating, and reinforcing a lot of the soil and the roots of this tree. Now, I'm mindful for the next 10 minutes or so, I am going to be talking about content that should make us all feel uncomfortable. That is the point of it. If we're not feeling uncomfortable by it, if we don't feel disrupted by it, that in itself should be a sign of a warning and something that you should really be able to reflect on. But at the same time, I want you to pay attention to your bodies and think about where you might start feeling not just uncomfortable, but actually feeling unsafe. And particularly for those of you who are joining us today virtually, who may actually belong to a number of communities that have been the most targeted but by a lot of the violence that I'm talking about, I encourage you to step away for the next 10 minutes if you need to. I won't take any offense to it, and come back and join us in 10 minutes or so after we've gone through these. But for those of you who may not actually belong to those communities where this knowledge may be, being shared with you for the first time, I encourage you to kind of sit and stay with your discomfort as much as possible. Have a cold glass of water, do something, fiddle with your hands, do something to try to stay with us, because I do think discomfort is a really strong pedagogical tool that can allow us to actually change behaviors and our own ideologies and way of thinking about the world. Okay, so with that said, I wanted to just ask, does anyone recognize who this is? And feel free to put this in the chat. Tommy Douglas. Yes. Thank you. I'm glad people know. So, father of Medicare, renowned Canadian. A lot of what he stood for is a lot of what we recognize as part of quote unquote Canadian values of benevolence and universal health care, et cetera. Unfortunately, a lot of what we don't learn about Tommy Douglas is the fact that in 1933, when he was graduating from his master's program, he studied the use of eugenics, particularly sterilization and segregation, in order to what he titled, limit the spread of subhumans, who he defined as women who engaged in sex work, people with disabilities, queer, trans, and non-binary communities, migrants, and particularly Indigenous people, and more specifically Indigenous women and children. And you would say, okay, it was just someone's master's paper. Later on in his career, he went and actually, apologized for the paper. But at the same time as he published it, and the title of his paper is Problems of the Subnormal Family, if anyone wants to Google it and actually read it, I think it is available online through a Google search. But at the same time as Tommy Douglas was publishing this was also the same time that BC had actually published their Sexual Sterilization Act. And a couple of years before that, in 1928, Alberta had passed the same act. And one of the things that I learned from reading the acts is that there was a board of eugenics, which included a social worker, a psychiatrist, and someone with legal representation that would, create a board of eugenics, and they would oversee the mass sterilization that we witness and we know about within so-called residential schools, within so-called Indian hospitals, as well as within other institutions that were created in order to incarcerate people with disabilities and, unfit women as a result of social values. So I encourage you to read this book by Karen Stoll, published in 2015, where she really traces this legacy and talks about how, even though this was legislated for sterilization, how has it now moved towards more coerced, unlegislated sterilization that continues to happen, particularly against Indigenous women. So I'm going to move on to another example. How many people have heard of the term drapetomania? No. Okay. That's helpful to know. So again, trigger warnings all around the board here. So drapetomania was one of the early diagnoses created within our healthcare system in North America. And it was created by Samuel Cartwright, whose paper you can actually read. It was published in the New Orleans Medical and Surgical Journal in 1851. And he basically described, and I'm going to actually read quotes from the place here, but he essentially created this diagnosis that he termed that enslaved Black people who had the urge or attempted to flee their enslavement were actually inflicted with this psychiatric diagnosis of drapetomania. And he suggested things like, proper medical advice strictly followed will allow the troublesome practice that some enslaved Black people have of running away to be entirely prevented. He had prescriptions in his article, such as whipping the devil out of them as a preventative measure, and he believed the ultimate remedy for this disease would be for physicians to physically remove the large toes of enslaved people in order to make running a physical impossibility. And so this is very much part of our legacy within the healthcare system. Of course, not something that a lot of us learn about. And I, shared this book here by Gary Geddes because one of the things that I also didn't learn about in my own clinical education was this idea that, we often hear about Indian agents within, reservation systems who were very much responsible for the abduction of a lot of children within so-called residential schools. What we also don't learn about is that oftentimes the Indian agent, that appointed by the state of Canada was often also a physician and had the capacity to detain any Indigenous person in these so-called Indian hospitals if there was a fear of a communicable disease. Now, they didn't need any proof. They didn't need any substantial evidence that there might be a communicable illness, but they were actually able to detain anyone and have them, held within these institutions called hospitals. Hospitals, again. And I think what was really troubling and important, I think, for me to learn from the book was that our healthcare system has been really instrumental in actually carrying out and enacting this idea of terra nullius, this idea that the land is barren, Indigenous people don't exist, and therefore colonial settlers can actually take the land. Our healthcare system allowed that to happen by incarcerating Indigenous people and removing them off of the territories and into these so-called institutions. So I encourage you to read about that as well. And since we're talking about overdose deaths, I feel like I can't not talk about Emily Murphy. So how many people have heard of the origins of the Opium Act of 1908 and have some sense of, the history around that, where it came from? It's okay if you haven't. It's good to see a no as well, just to better a bit. Okay. No, some have said yes. Okay. Okay, perfect. So, really briefly and mindful of time, the 1908 Opium Act really, I appreciate recent learning from me. Thank you so much for sharing that. I think it's important to voice that. I learned about this from people who use drugs directly, who taught me this history, not from our healthcare system or our clinical training, of course. But essentially, the initial act came out of anti-Chinese, specifically xenophobic riots that occurred in Vancouver. And in order to appease a lot of the white rioters, the government in Ottawa enacted the initial Opium Act in order to make the import, manufacture, possession, and selling of opium an illegality at that point. And a lot of the punishments for this was also included whipping. Again, a similar theme that we're seeing in terms of how physical harm is enacted, but it also included deportations. And by 1922, almost 3/4 of those who were convicted by this particular drug law were Chinese and faced deportation. And then, of course, we have the 1923 expansion of the Opium Act, where 3 new drugs were added, including marijuana. And this is where Emily Murphy comes in. And I encourage you to read this Vice article, since I won't be able to go into it in as much detail as I would love to. But essentially, the year before the 1923 Opium Act expanded to include 3 new drugs, the year before, Emily Murphy published this book called The Black Candle. Has anyone heard of it? Has anyone read it at all? So, feminist hero of Canada. There's videos about her. There's articles about her. We know who she is, but we don't know about this particular history. And in this book, essentially what Emily Murphy was proposing was that there was an international conspiracy by non-white people who have somehow banded together to corrupt the purity of the white race through the use of drugs. And she particularly talked about how particularly white women who had sexual relationships with Black and brown men were doing so because of the influence of substances, which is why we need to expand our prohibition laws and include things like marijuana. And she, proposed that a lot of the response needs to be to deport and she explicitly said racialized people, Black and brown people, need to be deported as a result of this. And so, yeah, please add it to your reading list. I think oftentimes we think about, Harry Anslinger and the war on drugs in the US as really the foundation of the racist war, without really, whitewashing our own history in Canada that is very much rooted in racist, xenophobic, and settler colonial legacies, which again, I'm not going to be able to go into. So I encourage you to, read this one particular CBC Radio article that I feel like summarizes it in the shortest time possible. Okay. The examples I'm sharing here are really just looking at how we pathologize issues of social justice, so things like drapetomania, and we criminalize people as a result of those roots of that tree, and in order to actually engage in violent conquest, which is, continues to exist within settler colonial Canada. Okay, how many people have, I'm going to do a quick time check for myself. Okay, we're good. How many people have heard of the SIM speculum, particularly those of you who might work in OB-GYN, ORs, hospitals? Ever heard of it? This is what it looks like. So, it's named after Miriam Sims, who's seen as the father of modern gynecology. And you'll notice there's a lot of fathers of so many of these things, father of Medicare, that we often end up talking about. And Miriam Sims, who is a renowned and continues to be a renowned American surgeon, has a lot of instruments named after him, including this one that we continue to use in our ORs. And the reason for it is because he developed a number of surgical techniques to repair gynecological issues, but he experimented on enslaved Black women because, just like Samuel I'm forgetting his last name at this point, person who created drapetomania, Miriam Sims, also was a slave owner in addition to being a physician. Again, part of the history of a lot of these fathers that we don't learn about. And so he experimented on enslaved Black women who were under his control and did so without using any anesthesia because he felt that Black people, again, a stereotype that continues to exist in present day, somehow have, shorter nerve endings or all kinds of other biological justifications for injustice to justify the fact that somehow Black people experience less pain. And at the same time as he was experimenting and he started performing the surgeries on white women in the same era, he was doing so with anesthesia because he recognized that white people, including white women, were full humans capable of experiencing all the emotions, including pain. And how many people have heard of Stephanie Warner, particularly for those of you in the GTA who are joining us virtually? Yes, okay. So some people are no, and yes, unfortunately, yeah. So Stephanie was someone who was met with physical restraint by hospital security at Toronto General Hospital in 2020, because I shared a lot of historical examples, and if we had more time, I could do the whole arc and share everything from history to present day, but I wanted to leave with some more present examples so that you don't think that this is just something that exists in the past. It very much continues to manifest in the future, and encourage you to learn more about Stephanie Warner's death as she was waiting for emergency care at Toronto General Hospital a couple of years ago. Guards actually physically moved the camera that was facing her before they presented to her. And what we know from the altercations is that it resulted in her asphyxiation and her death. And we talk often about intergenerational trauma, which is why I wanted to share this story here about Daisy Warner, who was actually Stephanie's daughter, who died in November of 2021, so last year, roughly a year after her mother was killed within one of our hospitals. And really thinking about the fact that, Daisy died within one of the hotels that were created and built by the city in order to allow for physical distancing among unhoused community members in the GTA. And I want you to think about how we witness, how we participate in the dehumanization of people who use drugs that allow for deaths to continue to happen without much scrutiny or accountability from within our establishments. And that's really why I wanted to share this particular quote at the end of this very short, quick historical timeline to really talk about, the fact that as physicians in particular, so for those of you who are physicians within the virtual environment here, but also as all healthcare workers, we do have a lot of institutional backing and a lot of political power to be able to act in oppressive ways, whether we're, subconsciously hold oppressive ideologies or consciously do so. And I would say that all of us subconsciously do hold oppressive ideologies. None of us are able to be immune from that, since that is literally what our society is built on. It's important to recognize that we're able to do that with, very limited public knowledge, let alone public scrutiny, consequence, or accountability. So hopefully this quote here helps make sense of that. It's not just the fact that we may hold the subconscious oppressive ideology, it's the fact that we actually have the power backing us in order to be able to act on that without significant consequence. Summarizing it, well, maybe not summarizing, to come to the conversation around, well, medical violence, those roots of the tree, and the drug poisoning crisis, how are they related? So we acknowledge, I hope we can all acknowledge that all kinds of people use substances, and may experience some harm from the use or may not experience harm from using psychoactive substances, whether they're legalized or illegalized, as a result of often the unearned advantages and privileges that some of us hold, versus others who actually bear the brunt of the roots of this tree, who will actually experience the most harm and consequences from substance use, and particularly psychoactive substances. But I forgot to go through this. I thought we were going to do this earlier. My bad. So let me actually step back. Before we talk about the drug poisoning crisis specifically, I want to just wrap up this tree and how I feel like the soil and the roots of this tree actually manifest to create these downstream health consequences. So at the systems level, which is what the roots would be, very much created through the use of power and capital. And by capital, I mean social capital and physical capital in the form of finances and resources. Often happens through expropriation. So again, the theft of indigenous land, water, and resources, as well as exploitation. And then at the institutional level is where I really feel like the roots of this tree manifest, where people will compete, people will marginalize each other in order to get closer to power. And those of us who are not able to participate in that, demonization, domination, and dehumanization of each other are often the ones that are seen as most disposable and therefore are kind of pushed to the most margins of our society. And we will see the consequences of that at the individual level through the form of criminalization, incarceration, deportation, as well as death. And what I would call is, structurally manufactured erasure by our institutional policies, by the whole tree. So hopefully that summarizes that and makes sense. Okay. Now, in terms of talking about back to the drug poisoning crisis, so hopefully, people have a good understanding as to why some people who are particularly bearing the brunt of the harm of the roots of this tree would use substances in a way that we may determine to be problematic, but who may be using substances, irrespective of the harm it may be causing them physically, emotionally, or those around them, in a way to actually either support themselves through their trauma or actually experience pleasure and joy at a time when most people wouldn't be able to do that when they're facing the brunt of the violence of the roots of this tree. And then hopefully with that brief conversation around our drug laws and our drug policies, I hope you could understand how the roots of this tree are very much manifested within our drug laws and the iron law of prohibition that continues to produce increasing amount of death, and I would say social murder because of the impacts of prohibition, which I realize a lot of medical trainees who come and work with us often ask, why is that? Why is it that prohibition continues to produce more and more toxic, more and more unpredictable drug supply? And can anyone in the room potentially just explain why that is, just to make sure everyone here understands this point? Because I think this is one of the things that gets missed somehow in medical education. So why does prohibition produce increasingly toxic, volatile, and unpredictable street supply of substances? Yeah, exactly. There's no regulation because it's illegal to provide, so one way to think about it, the fact that it's unregulated, is when you criminalize something, you criminalize a particular behavior, then people need to find substances that would have the same psychoactive effect as something else. So for example, fentanyl as opposed to heroin, because you could actually move fentanyl in much smaller amounts in order to get the same amount of effect that someone who may have been using the much greater amount of heroin was getting. And in terms of all the other unpredictability we see in street supply, continues to change and continues to shift to try to get through all the mechanisms that have been created through our so-called criminal justice system to try to find illicit substances. And so hopefully that makes sense in terms of how the iron law of prohibition continues to produce that toxicity. If it doesn't, I encourage you to read this particular article. It was published earlier in our current drug poisoning crisis, but I think it still gets to the point. But I think one of the pieces that often gets missed is the fact that our healthcare system is very much part of this process of prohibition and violence, particularly against people who use drugs. I encourage you to read this particular thread that really summed it up in terms of how, what I was speaking to earlier, when we just continue focusing on just the downstream fruits and the branches of this tree, and we continue to avoid thinking about, learning about, let alone actually addressing and trying to dismantle the roots of this tree, we continue to make substance use an individual problem that needs to be dealt with either through the creation of disorders, whether that's through our healthcare system or through our so-called criminal justice system. And so hopefully that makes sense in terms of why we continue to see the drug poisoning crisis escalate despite us trying to so-called expand access to healthcare services. So what do we do with all of this? I'm going to spend another 10 minutes or so, maybe 15, to go through this, because I think we started at 11:40, not 11:35. So hopefully by 12:30 to 12:40, we can do Q&A. Okay. So in terms of, next steps, oftentimes people will say, okay, well, it's helpful to understand this, but what do I do? And I can't tell you what to do. We're all autonomous beings who need to figure out what makes sense for us. But what I'm hoping to do is just share some ideas that have helped inform my actions and my behavior and have allowed me to better understand what I need to move and what I need to unlearn in order to shift things towards greater justice in the world. So just like oppression manifests at the internalized, interpersonal, institutional, and ideological levels or society level, I think so too do all of our actions. And I think it's important to recognize that if we are working on ourselves internally or at the interpersonal level, we have to acknowledge that that in itself will have ripple effects and shift things at the ideological level. And simultaneously, I think we have to, for those of us who may be working at system level change, we have to acknowledge that we can't do that work without also focusing on our internal and interpersonal lives in order to ensure that we're actually building the skills we need to exist with each other with greater dignity and respect. And that's why I share this quote from the brilliant sci-fi writer Octavia Butler: all that you touch, you change. All that you change changes you, which I truly believe is the case and something that we need to do. Okay. So in terms of at the interpersonal as well as at the internalized level, something that really helps me is this idea of embracing discomfort and dissolving the guilt that can sometimes come up as a result of this discomfort. And we talked about this in the short timeline that we did, the importance of discomfort as a pedagogical tool, but also as a tool for motivation for action and change. And the question that I asked at the beginning, right? Like, how skilled are you to pick up the fact that you may hold particular assumptions, attitudes, or act in ways that may actually make someone else feel marginalized or excluded or dehumanized? And recognize that that's a skill of self-reflexivity, and that reflexivity and being, critically reflexive about ourselves and how we exist in the world can't happen in isolation. It has to happen in conversations with other people. And I think how we speak, what language we use matters, and also how we then act matters. And I really liked this particular tweet from Sophia Bartlett, because we often talk about barriers to treatment. We often talk about hard to reach patients. And how about flipping that to actually think about hard to reach services, hard to reach physicians. And I say that not just physically being hard to reach, but emotionally, having physicians that are emotionally safe to actually be able to access and reach as well. And then I think for me, in terms of how I practice clinically, it has to be from a place of solidarity and not from a place of charity or superiority, which is very much how our healthcare system and our education system has been grounded in. And for me, when I think about the difference between solidarity versus charity or superiority, is very much this idea of recognizing that this is a verb, not an action, and seeing ourselves as healthcare workers having a particular set of knowledge and skills and offering that knowledge and respecting people's decision, like what we would call informed consent, but doing that every day and every second of every day as clinical providers, and respecting people's decisions to either accept what you are offering, the resources, skills, or knowledge you're offering, but also respect when people decline what you're offering as well, and continue to ensure that you're continuing to support people in ways that still respects their dignity and their power, as opposed to you somehow having a, so-called altruistic idea about saving other people. Okay. I'm going to move to the institutional level. I think for me at the institutional level, it really is about collective power, right? A lot of people are like, there's no way I could take any of this on. And you're right. None of us can take any of this on as individuals. That's not how it's meant to be. These structures and the roots of that tree are deeply entrenched, and they're made up of all of us as our institutions, as are our clinics. And in order for that to shift and to radically be dismantled and recreated, requires all of us to be working in solidarity with each other. And so for me, I think, this idea that our history somehow will continue to inform our future is not an inevitability. I think our history does not have to actually be our legacy today. And for me, I think part of that is, yes, doing a lot of the work of learning and unlearning, but also not stopping there. I really like this quote from Paulo Freire, where he says, education does not change the world. Education changes people. People change the world. So how are you organizing with others, whether it's within your clinics, your hospitals, your programs, in order to disrupt the harm that you witness on a day-to-day basis and to build anew? And then also, how are you working with people outside of the institutions you belong to, because of the inherent contradictions that exist within our institutions in order to create about change. And then at the institutional level, this concept of centering the margins brought to us from Black feminists and third world feminists, particularly through, frameworks like intersectionality, is this idea of taking leadership from those who are most pushed to the margins of power within our communities. And what would it look like if our clinics, our programs, our hospitals were actually built, imagine having board of directors of our hospitals that weren't full of, CEOs and or other people from large corporations, particularly in mining and in finances, but instead were made up of community members who existed within the vicinity of that space, who experienced the most structural marginalization, as well as being built by the most underpaid workers within a particular center. What kind of changes would you see happen to the environment, to the policies, to the services that are offered in order to be able to access care? And, I really like this quote from Chandra Mohanty, and I encourage you to read this paper. It was a foundational paper for me many years ago when I did read it. This idea that when we begin our analysis and we stop it to the space of privileged communities, our visions of justice are going to be exclusionary, because those who are closest to the problem are also the closest to the solutions. And then I also really like this quote from Monique Tula, who's the executive director of Harm Reduction Coalition in the US, where, she says, so when we talk about harm reduction, we often reduce it to a public health framework, one of reducing risks. That's harm reduction with a small HR. Harm reduction is meeting people where they're at, but not leaving them there. But harm reduction with a capital HR, this is the movement, one that shifts resources and power to people who are most vulnerable to structural violence. How are our literal programs and policies and services actually allowing power and resources to move to those who are most vulnerable? Because in order for us to center the margins, we have to recognize that those of us closest to power actually do have to decenter ourselves, as well as shift the resources available to us into the hands of those who are most to the margins. Another way to think about this is this idea that, we might have a new technology that gets built or a new program gets created in medicine, particularly in the GTA, I'm sure all across North America. Usually it's followed by like 10 years of research as to why X, Y, and Z structurally marginalized communities couldn't access that said program or technology or new intervention or new drug. What about actually building those new quote unquote innovations that don't actually leave people behind and don't actually continue to progress through harming other people, and actually center those who would be the hardest to be able to access the services in the first place? So hopefully that makes sense for some people. Okay, finally, at the society level, what are the behaviors, what are the actions, what are the learning and unlearning we're doing at our internalized, interpersonal, and institutional levels that actually support large-scale movements for Indigenous sovereignty, Black liberation, and grassroots movements for justice and collective liberation of all people? And I want to make sure that none of you leave today thinking that those who've borne the brunt of harm and violence through the roots of that tree, including within the healthcare system, have somehow never resisted it. It's quite the opposite. So here, I share with you a photo of a sickle cell anemia testing that the Black Panthers ran, where they tested thousands of people within the US and shamed the Nixon government into actually creating a formal sickle cell training program. And then here's a photo of one of the Young Lords, a Puerto Rican self-determination youth organization, grassroots organization. They had chapters all across the country, similar to the Black Panthers, but this one is particularly from the Young Lords chapter in New York, where they decided to actually overtake the Lincoln Hospital after reports came out that children, adults, other people who were being admitted to the hospital were actually leaving with lead poisoning because of the terrible infrastructure with which people were getting care. And I love reading the demands, because I think about what our healthcare system would look like now if we actually met the demands of the Young Lords who had overtaken and occupied that hospital, and where 50% of the clinical staff in the emergency room at the same time as when they occupied stayed with them and carried out the occupation. So I also asked myself, how can we be those people? Okay, of course, I see the names here of some of the folks very much involved in the Moss Park tents, where people decided to illegally occupy and build the first unsanctioned overdose prevention site in the province of Ontario, pushing the Ontario government to expand funding to all the different overdose prevention sites we now know of, which we also know are still deeply inefficient. And then, of course, the Drug User Liberation Front that is enacting actions, again, often actions that are deemed as illegal, in order to show the rest of the world, in order to expand all of our imagination of what is actually possible when communities most directly affected are calling for solutions to address the crisis. So you can read more about it and also contribute on the links here. Ultimately, though, how do we actually practice the idea of nothing about us without us? How do we actually support at the grassroots level self-determination of communities who are leading change? Because oftentimes we somehow within the healthcare system think that's not happening, but it's, you know, by design that we often do not learn about the fact that it's not happening. And how do we move from, you know, us talking and people dying to us listening and to us being more informed in our collective action in order to stop more and more people from dying from overdose deaths? Okay, I'm going to leave it at that for sake of time and questions. Here's a summary of what I would say are anti-oppressive praxis or practices that I follow to combat the way that oppression manifests, from the, you know, the roots all the way to the branches to the roots to the fruits of the tree. And then there's a link to the article that I was referring to where you can learn more about this particular concept and how it helped me process through what I was learning as a medical resident. Okay, I'm going to leave it at that and ask for your questions.
Thank you so much for that, Nanky. That was absolutely mind-blowing in terms of the amount of information that you presented there. I was wondering if, based on your experience and the readings, especially around, like, I also am a person who has done a lot of formal education. And so much of what you presented here today is not what we learn about in our classes. We tend to learn a very particular worldview, a very particular Eurocentric perspective on health and what constitutes health and what constitutes health promotion. And I was wondering if there is one big takeaway message that you would like to really emphasize that people have as they move forward in trying to unlearn some of this white supremacy that is very much baked into our education system right now.
Yeah, I mean, I think when I was in the earlier stages, when I was uncovering a lot of the lessons and the teachings that aren't covered within our formal curriculum. Oftentimes, these would be about things that were deemed illegal, and these would be talked about in really vicious ways in order to keep them really alienated from the rest of community. And I would say that one of the things that was really important for me was to remind myself of where my loyalties ride. Am I going to be uncritically loyal to the institutions that have formally taught me where I'm formally working, or am I going to be loyal to communities that continue to bear the brunt of harm and learn from them? And I think if you haven't sorted that out yet, you will continue to, I'm sure there's like a famous Malcolm X quote of like, continue to hate people who are demonized within media and popular culture, which is all by design, of course, right? So I think that would probably be my biggest takeaway. Where are your loyalties at? Who are you actually loyal to within your work? And how do you shift your actions and your knowledge gathering as a result of that?
Thank you. So there was a comment about how much people really appreciated the material today and looking forward to gaining more knowledge in order to improve their own learnings on this. And then the follow-up question right afterwards, which I think ties in really nicely, is how to gain access to some of the suggested links and readings in your presentation. Because I think that there was just so much there that was very, very interesting and eye-opening to people.
Yeah, I'm always debating, do I strip away everything and just talk about like 3 things and get the point across? Or do I just try to share as much possible in one link so that people can basically just be intrigued enough to start kind of going on their own process? I always end up going to the latter because I know this is information I didn't get in my clinical training, and information that I continue to speak with other clinicians about who still don't have access to. And so I will put the link to the Prezi in the chat, but I think the video of this will be available publicly. And I will also post the Prezi on my Twitter account. But you can also email me if you want to get access to it. It's available publicly. I think if you even Google my name and Prezi, you should get a list of them, and this would be the latest one in there.
One of the things that came up in the chat while you were presenting on it was the questions around the unregulated drug supply, and how, and you just mentioned this as well, when you were talking about how so many of the actions that people are taking to combat the structural violence that's really baked into the system are quote unquote illegal actions. And so I was wondering if thinking about the actions that are necessary to combat the current extremely toxic drug supply that we're seeing. Um, there is, like you mentioned, Dolph. I was wondering if we could think about like pushing forward through the over-regulation. I mean, we all know just how destructive the criminalization of drug use has been
Yeah.
for people who use drugs, as well in terms of just like the way it bolsters the prison industrial complex, the way that this negatively impacts racialized, in Canada, particularly Indigenous people. And so I was wondering if you could think with us a little bit about pushing past kind of
Yeah.
like, some of the kind of like, standard responses we hear about into some of the ways that we really need to be thinking about breaking down the barriers. Um,
Yeah.
and again,
I'm
there.
surprised I didn't say it myself because I that is the main takeaway. I think oftentimes, particularly in these conferences, we will talk about, how do we improve our programs? How do we get access to more treatment? And I hope if there's anything you've taken away from the session today is that we can't actually medicalize our way out of any social injustice, including the drug poisoning crisis. And I think if we actually listen to what people on the ground are saying, people with lived expertise, like a lot of the examples that I gave you, I think it is our responsibility when we look at operating at that whole tree. It's not just working with our patients, our clients at the interpersonal level, or even within our institutions. I think at the societal level, at the ideological level, we all, as healthcare providers who continue to make a lot of money around the medicalization of substance use, actually need to be committed to not just calling for full scale decriminalization of all drugs without any, determined minimums, often determined by the cops themselves. And beyond that, we actually need to call for full scale regularization of all substances in order to actually end the overdose crisis, because decriminalization might help disrupt the cycle of harm through criminalization and through the ways that people, move and share psychoactive substances that are criminalized, but it's not going to address the fact that prohibition continues to drive the toxicity. In order to address that, we actually need access to a regulated supply. People need to actually know what they're getting when they get it, just like we do when we go get alcohol at the LCBO. So I think full-scale regularization of all substances needs to be the bare minimum, needed to be the case a long time ago. And I think if we think about where those drug laws of prohibition came from, with the conversation we had about Emily Murphy, alcohol bans on reserves, like the roots of this is very obvious in terms of the harm that it was meant to produce. If you Google Harry Anslinger, you can read about the overtly racist things that this man said, who orchestrated the war on drugs in the US that continues to influence the rest of the world as well. So recognizing where it comes from, the only way to actually dismantle the oppression baked into these policies is by ending them and regularizing.
And there's a question in the chat that I think is a nice follow-up to this in terms of what can healthcare workers do specifically to help support the decriminalization and the legalization of drugs. And also, I'll just nod. Thank you, Shay, for finding Nanky's Prezi and for putting it into the chat there.
Yeah, I think that's a great question. I think, is Zoe still here in the room? One of the things that I often tell people that Zoe told me a long time ago was, if you're at the table somewhere, I don't see her. If you're at the table somewhere and you're not feeling uncomfortable and you're not feeling internally, shaky, your voice is not shaking, and you're not pushing things forward, then you're not the right person in that room. The reason I say that is because a lot of cities are now building these decriminalization panels where people are being consulted, people are being asked to provide input. Oftentimes, healthcare workers or health policy experts are the ones who are approached for this. And I think we have to ask ourselves, how do we engage in actually pushing for decriminalization? And when do we decide that we're not going to engage in an institutional process that is already set up in order to continue to empower the criminal justice system? Because again, if we're working in ways that reinforces power, even if we think that there might be some trickle down, this idea of trickle down social justice, if we just get this much, if we get decrim with, a tiny amount as the maximum what people can actually hold, it will still help some people, it's false. Just like trickle down capitalism doesn't work, trickle down social justice doesn't work. We need to be able to build justice in a way that actually meets the needs, again, of those most at harmed. And we need to do that through leadership from communities. And so I would say, connect with local organizations of drug users who are doing a lot of work, not just on decrim, but also on regularization and legalization. I'm happy for you to reach out. I'll put my email in the chat to make those connections if they aren't already there for you in your communities. I'm sure Gillian would be an excellent resource for that as well. And many of the participants who are here, whose names I'm seeing as well. So feel free to put in your name if you are from a particular city and you're a healthcare worker and you want to connect with someone who may be in that space as well.
Here, Nanky, thank you so much for such an inspiring and really, really deeply thought and felt presentation. I so much appreciate that.
Thank you. Thanks, Gillian, for asking me to come.